Welcome to the deep dive. Today we are taking you into a high-stakes environment where you would normally expect, well, absolute, infallible precision.
Right, because usually when we talk about a medical monitor, there is this expectation that it works like a fuel gauge in a car.
Exactly. You look at a screen, you see a blinking red light or a plunging line, and the machine is basically screaming, like, here's the exact problem, fix it right now.
It's a comforting idea. I mean, we really want technology to be binary and objective, especially in a hospital room.
But then you step into a labor and delivery ward. You look at the monitors tracking a baby's heart rate during birth, and suddenly that fuel gauge analogy just falls completely apart.
Oh, it crumbles. It is the absolute definition of diagnostic muddy
That's
waters.
right. We are looking at a diagnostic landscape that is, honestly, incredibly murky. Millions of times a year, in essentially every hospital birth, medical teams rely on this tool that is just surprisingly complex to interpret.
The squiggly lines you see on those screens, they are not handing doctors a simple diagnosis on a silver platter. Not at all.
Which is why our mission for this deep dive is so exciting. Today, you, our listener, are going to learn how to read one of the most universally used medical tests in the world.
Fetal heart monitoring, or FHM.
Right. We are going to unpack how labor nurses and physicians use these real-time charts as a kind of code-breaking exercise to figure out if a baby is getting enough oxygen during birth.
And to crack that code, we first need to lay out the terminology cleanly. You will often hear this process called electronic fetal monitoring, or EFM.
Or sometimes CTG, right?
Yes, in some regions it's called cardiotocography, or CTG. But
Yeah.
practically speaking, what we are doing is plotting two things simultaneously on a graph over time. The top line is the fetal heart rate, so the baby's heartbeat.
And directly below that, on the exact same screen, is the bottom line, which tracks the mother's uterine contractions.
Exactly. That bottom line is recorded by a pressure sensor placed on the mother's abdomen called a tocodynamometer.
That's a mouthful.
It is. Most nurses just call it a toco for short. By looking at these two lines stacked on top of each other, clinicians can see how the baby's heart responds every time the mother's uterus contracts.
Let's unpack the mindset behind this dual graph setup, because the way the medical community views this tool has undergone a massive, really fascinating paradigm shift over the decades.
It really has. Back in the 1960s and 70s, when this technology first rolled out, doctors treated it as a new diagnostic tool.
The assumption was that this monitor was a crystal clear window right into the baby's brain.
The belief was entirely straightforward. They thought if the line on the paper looked bad, the baby was in immediate, irreversible danger and required surgical intervention.
But today, the stance is completely different. The major governing bodies, like the American College of Obstetricians and Gynecologists, ACOG, and the National Institute of Child Health and Human Development, view this purely as a screening tool.
Yes, a screening tool, not a diagnostic tool.
And I found this fascinating in our research. The medical community now uses this bizarre double negative to describe what they see on the screen.
The phrasing is very deliberate. Today, if a tracing looks abnormal, a clinician won't say the baby is definitively in danger. Instead, the official terminology is that the fetus is not in a reassuring metabolic state.
It's such a strange way to phrase a medical finding. I mean, it's like saying, well, we can't prove the baby is fine, but we also can't prove the baby is in trouble.
Right. It essentially means the squiggly line is just telling the medical team to look closer rather than, initiating an automatic emergency surgery.
That phrasing exists because the false positive rate of this monitor is incredibly high, isn't it?
Exactly. The line itself doesn't make the diagnosis. It simply prompts the human in the room to investigate the broader clinical picture.
So we have this ubiquitous technology that is simultaneously heavily relied upon and, well, incredibly ambiguous. How did we even get here?
It's quite a story. Before we get into decoding the modern squiggly lines, we really need to understand how we started listening to babies in the womb in the first place.
Because the history here is wild.
We have to travel back to 1818. A French obstetrician named Jean-Alexandre Lejumeau was wrestling with this exact problem. Now, René Laennec had just invented the stethoscope a couple of years prior.
The classic wooden tube stethoscope, right?
The very same. Lejumeau apparently heard horse hoofbeats one day and had a light bulb moment. He wondered if he could hear a similar rhythmic sound inside the womb.
Wow.
So he takes this brand new stethoscope, presses it to a pregnant patient's abdomen, and manages to hear the baby's heartbeat.
That must have felt like magic at the time. I mean, suddenly the baby wasn't just a mystery inside the mother. It was a patient they could actually monitor.
It revolutionized the field. For the next 150 years, the standard of care was intermittent auscultation. By the 1890s, Adolphe Pinard introduced the Pinard horn.
Which was essentially a specialized trumpet-shaped fetal stethoscope, right?
Exactly. Doctors and midwives would use it to listen to the baby's heart every 15 to 30 minutes during active labor.
I can't even imagine how labor-intensive that was, having a nurse lean over with a wooden horn every 15 minutes for hours on end.
And, checking the heartbeat by ear meant you could easily miss a baby deteriorating in those 15-minute gaps.
That was the exact fear that drove the technology boom of the 1950s and 60s, I bet.
Spot on. Clinicians desperately wanted a continuous picture. What's fascinating is how parallel the research was to achieve this. In New Haven, Connecticut, a Yale obstetrician named Edward H. Hahn started recording fetal ECG signals.
Let me pause you there just to make sure we're clear. When you say ECG signals, you mean he was measuring the actual electrical impulses of the baby's heart.
Yes, exactly.
Like the large sticky pads they put on a patient's chest in the ER, but somehow doing that for a baby still inside the uterus.
Yeah, Hahn figured out how to capture those tiny electrical signals and graph them continuously. By 1958, he was publishing the first electronic tracings that correlated the baby's heartbeat with the mother's contractions.
That is incredible for 1958.
Meanwhile, down in Montevideo, Uruguay, Roberto Caldero Barcia and his team were doing similar work. They actually coined the early terminology, calling specific heart rate drops DIPI and DIP2.
Which we now call early and late decelerations.
Right. And then over in Germany, you had Konrad Hemmecker developing the commercial machine that eventually became the prototype for what is sitting in hospital rooms today.
All of this innovation was driven by a desperate desire to prevent stillbirths and intrapartum brain injuries, right?
Entirely. Continuous electronic fetal monitoring promised to catch cellular deterioration in real time. Because of that promise, the adoption of these machines absolutely exploded across the United States in the 1970s and 80s.
Hold on. This is the part of the research that literally made me drop my pen. You're telling me hospitals across the country hooked millions of women up to these machines as the new standard of care before they actually proved they saved lives.
Yes. That sequencing problem, the technology outrunning the clinical evidence, is the ghost that still haunts obstetrics today.
It's just wild to think about.
The medical community was so terrified of missing a deteriorating baby that they adopted the technology universally before running the randomized controlled trials to see if it actually improved long-term outcomes.
That is stunning. But to understand why the evidence ended up being so complicated later on, we really need to dive into the physiological mechanics.
Let's do it.
So hospitals rolled these machines out everywhere. For the machine to actually warn doctors of danger, they first had to figure out what a normal baby looked like on paper. How do you even establish a baseline?
It starts with observation over time. A clinician looks at the tracing and establishes the baseline fetal heart rate over a 10-minute window.
Like a 10-minute window.
A normal, healthy baseline averages between 110 and 160 beats per minute. But the absolute most critical part isn't the average number, it's the variability.
Baseline variability. This is the beat-to-beat fluctuation in the heart.
Yes, exactly.
The sources outline that clinicians are looking for what they call moderate variability, which means the heart rate is constantly fluctuating by 6 to 25 beats per minute.
And that constant fluctuation tells us a lot about the baby's central nervous system.
Okay, let me try an analogy here to make sure I'm grasping this. Imagine a baseline heart rate, like a lively, engaged conversation at a dinner party.
Okay, I like that.
The volume and the pacing are constantly going up and down as people react to each other, right? That wiggly line on the monitor is the baby's autonomic nervous system having a lively conversation.
Yes, perfectly said.
It's the sympathetic nervous system, the gas pedal, and the parasympathetic nervous system, the brake, constantly adjusting and reacting to the environment.
That is a perfect way to visualize it. If the line is wiggly, it proves the baby's brainstem is well oxygenated and functioning beautifully.
So a flat line on the monitor, a completely quiet dinner party where nobody's reacting to anything, is actually a massive red flag.
Absolutely. The wiggly line is your best real-time reassurance that the baby is doing well. You want to see those continuous micro-adjustments.
Okay, so a wiggly line is a great dinner party. But what happens when the conversation suddenly stops and that heart rate drops?
This brings us to the absolute core of our deep dive, decoding decelerations.
Right, the heart rate drops.
And this is where we have to debunk a major rookie misconception right out of the gate. People naturally assume that a deeper deceleration, like a line that drops really low on the graph, is inherently more dangerous.
Well, I mean, it makes sense intuitively. If the heart rate drops from 140 down to 60, that feels like a bigger emergency than dropping to 120.
It feels that way, but deeper is not always worse. Clinicians do not read these tracings primarily by depth.
Oh, really?
Yeah, they categorize decelerations by their shape, by their timing relative to the mother's contraction, and by the underlying physiological cause.
So timing and shape are everything.
Yeah.
Let's break down the three main types of decelerations you will see on a monitor, starting with early decelerations.
Picture the mother's contraction on the bottom half of the screen as a smooth rolling hill.
Okay, I'm picturing it.
An early deceleration is a perfect, smooth mirror image directly above it. It has a gradual onset, a gradual return, and the lowest point of the baby's heart rate, the nadir, lines up exactly with the peak of the mother's contraction.
So the heart rate dips precisely when the squeeze is the tightest. What is physically causing that to happen?
It's caused by benign head compression. As the mother's contraction pushes the baby's head against the cervix or the pelvic wall, that physical pressure on the baby's skull triggers a vagal reflex.
Wait, like a vasovagal reaction?
Yeah.
Like when an adult faints at the sight of blood because their heart rate suddenly bottoms out?
Exactly the same mechanism. The physical pressure stimulates the vagus nerve, which hits the parasympathetic brake and transiently slows the heart rate down.
I really want to emphasize this for you listening. This is totally normal. Our sources give a great textbook example of this.
It's a great example.
Imagine a patient who is 8 centimeters dilated, deep in labor. The baby's heart rate dips from a baseline of 140 down to 125 beats per minute in perfect lockstep with the contraction, and then comes right back up.
Right, and the nurse watching that monitor doesn't panic.
No medical intervention is needed at all. It simply means the baby is moving down the birth canal.
That head compression is completely safe. The real warning lights start flashing when the timing shifts, which brings us to late decelerations.
Okay, so how does a late deceleration look different on the screen?
Visually, it has the exact same gradual, smooth, rolling hill shape as an early deceleration. The difference is entirely in the timing.
So it's shifted.
Yes. The nadir, the lowest point of the heart rate, happens after the contraction has peaked. It typically lags by 20 seconds or more, and the heart rate doesn't return to normal until well after the contraction is completely over.
I have to ask a question here about the vocabulary. Does calling it a late deceleration mean it is too late to help the baby? Or does it just mean it's more severe?
That is the ultimate trap medical students fall into. Late solely describes the timing relative to the contraction. It means the drop is delayed. It absolutely does not mean too late to intervene.
Got it. Good to know. So if the squeeze of the contraction happens, why is there a delay before the baby's heart rate drops?
That delay points to uteroplacental insufficiency. Think of the placenta like a sponge full of oxygenated blood. During a contraction, the blood vessels feeding that sponge are naturally squeezed, temporarily reducing blood flow.
Like stepping on a garden hose for a minute.
Exactly. If the placenta is healthy, the baby has enough oxygen reserve to ride out that squeeze without a problem.
Makes sense.
But if the placental reserve is already compromised, maybe due to maternal conditions like preeclampsia, low blood pressure, or a placental abruption that causes a delayed drop in the baby's actual oxygen levels.
And the baby reacts to that.
Right. The baby's chemoreceptors eventually sense this lack of oxygen, and it triggers a slower, delayed reflex to drop the heart rate to conserve energy.
So if a nurse sees a late deceleration, it's a sign that the baby's oxygen supply line is struggling. But I found this incredibly reassuring when I read it. Seeing a late deceleration doesn't mean the team immediately sprints to the operating room for a C-section.
Not at all. It triggers a standardized nursing resuscitation bundle. The goal is to fix the environment inside the womb to get that oxygen flowing again.
Let's walk through those interventions because the logic behind them is brilliant once you understand the mechanics. First, you reposition the mother, usually rolling her onto her left side.
Yep, the lateral position.
Why? Because you are taking the weight of the uterus off her major blood vessels, which immediately improves blood flow back to her heart and therefore back to the placenta.
Next, you administer SEVI fluids to boost her blood volume and provide supplemental oxygen.
And if she is on a drug like oxytocin to stimulate contractions, you turn it off immediately. You want to stop the uterus from squeezing so the garden hose can open back up.
Exactly. You are attempting to restore placental blood flow. You generally only move to an operative delivery if those patterns don't resolve, despite all those interventions, or if the baby loses that healthy, wiggly baseline variability we talked about earlier.
Okay, so early and late decelerations are smooth, predictable curves tied directly to the rhythm of the mother's contractions. But the third type of deceleration throws predictability completely out the window.
It really does.
What happens when the baby's heart rate drops out of nowhere?
That brings us to variable decelerations.
The name says it all. On the monitor, these don't look like smooth hills. They have an abrupt onset and an abrupt return, usually dropping and recovering in under 30 seconds.
Right, they look jagged, like a U, a V, or a W shape scribbled on the paper.
And their mechanism is entirely different from head compression or placental insufficiency.
Yes, completely different. The variable decelerations are caused by umbilical cord compression. The cord itself is physically being pinched.
Which could happen for a lot of reasons, right? Could be a neutral cord where it's wrapped loosely around the baby's neck.
Yes.
Or it could happen because of low amniotic fluid, a condition called oligohydramnios, meaning there isn't enough water in the womb to cushion the cord from being squished against the uterine wall.
It could even just be the physical position the baby is in as they descend. The crucial nuance here is that most variable decelerations are mild and mechanical. You can often fix them simply by having the mother change positions to let gravity physically unpinch the cord.
But there are atypical variable decelerations, right, where the cord compression is more severe.
Yes, that's where the heart rate is slow to return to baseline, or maybe there's a strange secondary spike in the heart rate right afterward called an overshoot.
Oh, an overshoot.
If you start seeing that, or if the tracing loses that wiggly variability, it tells you the compression isn't just a brief mechanical squeeze anymore. The baby is actually starting to experience evolving hypoxia.
They're slowly losing oxygen, and if we zoom out to the extreme end of the spectrum, there's a fourth, much rarer category called prolonged decelerations.
Yes. These are sudden drops in the heart rate that last anywhere from 2 to 10 minutes.
2 to 10 minutes, those sound terrifying.
They can be. They usually result from any of the mechanisms we just discussed, but taken to a catastrophic extreme, like a cord prolapse, where the cord drops down past the cervix, or a uterine rupture. Those are true, immediate emergencies.
But what happens when the tracing is just ambiguous? When it's not a clear-cut 10-minute drop, but it's not totally reassuring either? How does a doctor decide what to do?
That's where adjunct tools come in to gather more data. One method is fetal scalp stimulation. During a cervical exam, a clinician will gently rub or stimulate the baby's scalp.
Okay, why?
They are looking for an acceleration, a reassuring rise in the heart rate of at least 15 beats per minute for 15 seconds.
I love the logic of this. If the baby responds to a head scratch by accelerating its heart rate, it proves the autonomic nervous system is intact and well oxygenated enough to react to a stimulus.
Exactly. It provides instant reassurance. There was another adjunct tool developed in 1961 by Eric Saling called fetal scalp blood pH sampling.
The idea was to literally take a tiny drop of blood from the baby's scalp during active labor to directly measure the oxygen and acid levels.
It was a theoretically brilliant concept.
But from what I read, it largely failed to catch on in the U.S. because it was just too technically difficult and invasive to perform in the middle of a chaotic labor.
It struggled with practical execution. Which brings us to the most critical and perhaps most controversial part of this entire deep dive.
Yes, the counterintuitive truth.
The big reveal.
So we have this incredible, universally used technology. We know exactly what these shapes mean. We have standardized nursing interventions ready to go. Continuous monitoring must have practically eradicated birth injuries like cerebral palsy over the last 50 years, right?
This is the biggest bombshell in the entire field of obstetrics. The answer is no.
I am still wrapping my head around this. I'm sorry. We adopted a universal technology to protect babies' brains, and it doesn't reduce cerebral palsy.
Let's look at the data. The largest body of evidence comes from randomized controlled trials conducted in the 70s and 80s once the medical community finally decided to test the technology they had already adopted. The most famous is the 1985 Dublin trial, which enrolled nearly 13,000 women. Later, all these various trials were pooled into massive Cochrane systematic reviews led by researchers Zarko Alfirovich.
And the findings were an absolute earthquake for the medical establishment.
Oh, completely.
These trials found that continuous electronic fetal monitoring does reduce neonatal seizures compared to just listening in intermittently with a stethoscope. But and this is a massive bet, but it does not reduce the overall rates of cerebral palsy.
It does not.
It does not reduce perinatal death, and it significantly increases the rate of C-sections and operative vaginal deliveries like forceps or vacuums.
It is arguably modern medicine's most counterintuitive fact. We adopted a technology population-wide, defended it for decades as the ultimate shield against brain injury, and the highest level of clinical evidence shows it simply does not reduce cerebral palsy.
It's hard to process.
ACOG and the American Academy of Pediatrics have actually published task force reports acknowledging this.
Wait, if we are measuring the baby's actual oxygen responses, how is it possible that this doesn't prevent brain injuries?
Because the positive predictive value of a non-reassuring heart rate pattern for actually predicting cerebral palsy is incredibly low.
Okay, so what does that mean practically?
Essentially, a drop in heart rate doesn't automatically equal irreversible brain damage. Babies are incredibly resilient and have profound physiological mechanisms to survive temporary oxygen deprivation during birth.
That means the false positive rate of this machine is sky high.
Yes, exactly.
The overwhelming majority of these abnormal tracings happen in babies who turn out to be perfectly neurologically normal.
And that leads to the other major failure point, Howman error and the limits of interpretation. It's a problem of inter-observer reliability.
Inter-observer reliability, meaning humans reading the exact same chart disagree on what it says.
Radically disagree.
Yeah.
Different clinicians will look at the exact same strip of paper, the exact same squiggly line, and completely disagree on how dangerous it is. In retrospective studies, even the same clinician looking at the same tracing a month later will sometimes give it a different grade.
And this is true even with the National Institute of Child Health and Human Development. Trying to standardize everything into a strict Category 1, 2, and 3 system?
It doesn't matter.
If the diagnostic tool itself is inconsistently read by the humans looking at it, its clinical value is inherently constrained, no matter how solid the underlying physiology is.
Which leaves us with a paradox. ACOG explicitly states that intermittent auscultation, just listening in every so often, the old-fashioned way, is perfectly fine and evidence-supported for low-risk patients.
So why is continuous monitoring still used on almost everybody who walks into a hospital in labor?
Because obstetrics operates in a highly litigious environment. Abnormal fetal heart rate tracings feature heavily in birth injury lawsuits.
Oh, I see.
So even for low-risk patients, hospitals maintain near-universal continuous monitoring. It is a genuine tension between what the clinical trial evidence actually supports and what institutional habit demands.
It's defensive medicine. They are treating the monitor to protect the hospital against lawsuits, rather than just treating the patient. That is a heavy reality to digest.
It really is.
Well, let's bring this all together for you because we have covered a massive amount of ground today. If you take nothing else away from this deep dive, remember these core rules of the squiggly lines.
Right.
First, deeper is not worse. Timing and shape define a deceleration.
Early decelerations mirror the contraction and are caused by benign head compression.
Late decelerations lag behind the contraction and signal uteroplacental insufficiency. The sponge isn't getting enough blood.
Variable decelerations are abrupt and jagged, signaling umbilical cord compression.
And above all, moderate baseline variability, that lively, wiggly line that looks like a great dinner party, is the single best real-time sign of a well-oxygenated baby.
And you know, it is always worth remembering that fetal heart monitoring is just the intrapartum tool, the tool used during birth. It pairs beautifully with Virginia Apgar's 1952 Apgar score, which is the postnatal assessment used right after the baby is born.
Together, they give clinicians the full picture of the baby's journey into the world. It really is a complete relay race of care.
It is.
But understanding the history of this tool leaves us with something provocative to think about. We started this deep dive talking about the expectation of medical precision, the assumption that the blinking light on the hospital monitor is an absolute truth.
We want the perfect diagnostic machine, but humans are far too complex for that.
Exactly. As medicine continues to advance, we have to ask ourselves a difficult question. How do we untangle the tools that actually save lives from the tools we only cling to because we are afraid of lawsuits?
That's a huge question.
If the squiggly lines on the monitor are driving up surgical birth rates without actually preventing cerebral palsy, what does the future of childbirth look like? Are we going to keep treating the monitor, or will we find the courage to step back and trust the evidence?
It is a profound question, and one the entire field of obstetrics is still struggling to answer today.
And it's one worth pondering long after this conversation ends. Thank you so much for joining us on this deep dive. Keep asking questions, keep looking past the surface, and we will see you next time.